Good evening, all of you. I welcome all of you on behalf of the Urological Society of India to this webinar being conducted by the Uro-Oncology subsection of the Urological Society of India. Today we have an important topic on non-muscle invasive bladder cancer, practical solutions to the common problems. And we have three international faculty who are participating. I welcome all the faculty on behalf of the Urological Society of India. Now I would request our President, Dr. C. Mallikarjuna, to give his opening remarks.
Thank you, Keshav. Thank you very much, and welcome to this wonderful session on NMIBC. Inaugurating it, and it was a warm welcome from USI part to all the international speakers, Dr. Waite, Dr. Bakoneti, and my friend Dr. Manu coming over to this specific topic. I think we had two topics already today. One was on nocturia in the afternoon, and today we have NMIBC today. And I think it will be a great learning lesson for all of us. And I think the concentration is happening on case discussions here at Forts, which will be of great interest to majority of the Indian urologists. And I presume this will be a great session for every one of them. Thank you, Raghunath, for taking this. And I am sure that will be a great session. All the best to you all.
Now I would request Professor Rajiv Sood, who is the chairman of the Indian School of Urology, to give his opening remarks.
Thank you, Dr. Keshav. This is quite academically full day today, and we are having the second event, academic event, and this is important topic. Uro-Onco section of our USI and Indian School of Urology. This webinar is arranged, and this is one of the very important topic, non-muscle invasive bladder cancer, and especially we are focusing on intravesical therapies also. And in these therapies, one thing is important, that we are talking about BCG, we are talking about toxicity, we are talking about dosing, and also we have done some work here in India, and the Serum Institute, which the BCG, which they are now come out, that is instead of 120, 80 milligram dose is being used, and because efficacy has been proved, I was associated in that the trial also before approval. But one thing I'll tell, in the global shortage of BCG, there are many other options, the practical approach, which is differing, and also there are certain further advances, researches on BCG and BCG, the components and all the effective treatment which are in the pipeline. In this webinar of Uro-Oncology subspecialty, I welcome again all the three international faculty, our eminent Uro-Onco surgeons of the country. And I think today's discussion is really going to be very, very interesting and informative. With this, I welcome you all for this, and I give it back to Dr. Keshav.
Thank you, Professor Sood. Now I would hand over the proceedings to Dr. Raghunath to conduct this webinar. Over to you, Raghunath.
Thank you, sir. Very good evening to all. Welcome you to all this first Uro-Oncology webinar of the year 2021 and 2022. The topic for discussion of this webinar is non-muscle invasive bladder cancer. Management of it is relatively complex, even to understand, due to various risk stratifications. So we need to constantly follow them up with the cystoscopy, intravesical agents. Despite of this, they may recur and they may progress. And also they suffer from adverse effects of intravesical therapy. And a lot of changes have taken place even in the guidelines between 2020 guidelines and 2021 guidelines. To understand this complex topic, we have thoughtfully selected the topics and also the national and international faculty who are pioneers in this field. And at the end, we have practical case-based scenarios to understand this topic even better. With this note, I welcome the chairpersons for this session, Dr. Sudhir Raval sir, and Dr. Jagdish Kulkarni sir is not available for this because of his personal reasons. I welcome Dr. Sudhir Raval, who doesn't require any introduction. He's a pioneer in uro-oncology and robotic surgery in India, and a medical director of Rajiv Gandhi Cancer Institute. Welcome you, sir. And I request you to start the proceedings.
Thank you, Raghu, and I welcome all the international faculty, Manoharan, Raghu, Badrinath, and Christopher Wait. And I thank Raghunath and other organizing members of USI, Keshav, Rajiv Sood, and Dr. Arun Chawla, and President Mallikarjun for giving this opportunity. This is first webinar of this year after Keshav has taken as secretary. And NMIBC, we know this topic already has been introduced, and without delay, I would like to invite first speaker, who is Dr. Ginil Kumar, and he also doesn't need any introduction, but just to say that he's head of uro-oncology at Amrita Institute Medical College, Kochi, and he will speak on risk stratification of NMIBC and its clinical significance. Ginil.
Yeah, I hope my my slide is visible.
You can see.
Yeah. Thanks to USI and Dr. Raghu for giving this opportunity to me. If you ask me, the most important step in the management of CA bladder, without doubt, I will say that is the risk stratification. When you are hunting an animal, you should know the behavior and the habitat of the animal. Likewise, and then you have to select the weapon. Likewise, when you are attacking a disease or fighting with the disease, we should know the actual behavior of the disease. And bladder tumor is actually a bunch of different types of disease put together, like low grade and high grade behaves entirely different. So the first step for risk stratification was by WHO in 73, around 50 years back. The first pathological risk stratification, G1, G2, G3 system stood almost 50 years. And there was some issue because the grade 2, there were a lot of heterogeneous types of tumors, because whenever there is a doubt, the pathologists used to put these tumors into grade 2. So to streamline that, WHO came out with another pathological classification, that is three types of tumors. They stratified into three types: papillary, urothelial, neoplasm, low malignant potential, then low grade and high grade. And the grade 2 was put into low grade or high grade. So, but actually, has it reduced the confusion or increased confusion? Because when we look back after 50 years, we found that a better prediction was with the 1973 system rather than 2004, because the grade 2, a lot of grade 2 were migrate to high grade, and the high grade is the area where we have got a lot of confusion, because high grade itself has got a very high risk and a high risk category. Again, it is again going to change, because we are now going for a 4-grade system. Probably this may be a better option. Few papers has come on that, where the low grade is again divided into a low grade G2 or high grade G2. Grade 2 is again divided into either low grade or high grade, almost taking back the old WHO system. So this has showed a better prediction. But the pathological aspect is not the only factor. We have to combine the clinical factors also to predict the outcome properly. So the URTC risk table, which is available as bladder calculator, bladder risk calculator, was the most important step regarding this direction. This was actually after analyzing over 2,500 patients, where 6 factors were considered, both pathological and clinical factors, which are important for risk stratification, and the recurrence and progression was predicted. But URTC had some issues, because all these the prognosis may be further affected by intravesical treatment. This URTC risk table do not calculate the intravesical treatment, which is the common thing which the patient will be receiving after the initial treatment. There are other risk models which are useful in this aspect, like Queto model. They have a good number of patients who had BCG. Then the URTC had in 2016 one more study where the 1 year and 3 year maintenance BCG was used, and this risk predictor of that study found to be useful for in the BCG patients who had a BCG installation. So when we have an intravesical treatment, the original URTC table may not be useful. Again, these risk tables do not consider other clinical factors like age, gender, then the other factors like the early recurrence at 3 months, or a positive re-TURBT, a prostatic carcinoma in situ, or lymphovascular invasion, or even the rare events. So there are some shortcomings for this, all the risk models. Again, the intravesical treatment is, there is wide variation between different countries. The different patients may be getting different treatment. So all this is affect the prediction of risk. The latest attempt of risk stratification was the European Association of Urology's Prognostic Factor Risk Group that is published this month in EAU. They consider consider 3 factors. One is the risk factors. They are age, the tumor more than 3 centimeter, and the T1 lesions. Then the pathological group, whether they are low grade or high grade. The earlier PAN-NMP was included in the low grade. We can either use the low grade, high grade system or G1, G2, G3 system. Then the carcinoma in situ. Based on this one, they classify the risks are stratified into a low risk, which has got a single tumor, either TA or T1, and either there is no risk factors, or if it is a TA tumor, we can have one risk factor. So this is low risk group. Very high risk group, mainly it is the carcinoma in situ group with additional risk factors. Then high risk, and this has become a bit complicated based on the carcinoma in situ, the low grade. A combination of these factors are put to stratify into 4 risk groups: low risk, intermediate, high risk, and very high risk. This is probably the best option we have, and the earlier risk stratification group, everything will be vanished, because this may be predicting the outcome in a better way. And the risk stratification was properly predicted in at 5-year or 10-year with this system. But the story doesn't end there. There are different factors which are not considered. We know that the investigation like FISH can predict the outcome and also the recurrence early. There are nomograms like cypric nomogram. These are the inflammatory molecules that are used to predict the BCG failure and outcome. And also the molecular subtyping, lumina or basal, which can, the basal group may be more aggressive, which is seen in the invasive category of tumor, and luminal, which may not progress further. All these things may be useful for risk stratification, but why these are not used? Because this may not be useful at the community level. A molecular risk subtyping can again predict, not only predict the outcome, we can see which treatment may be the best option for these patients. Also, the machine learning and artificial intelligence may change the scenario in the future, because different factors has to be considered to predict the outcome. And when we are having a lot of factors which has to be considered, artificial intelligence and machine learning may give a better output rather than manual calculation. So this may change in the future. So risk stratification is very important to stratify the risk and have a risk-based approach for the management. And it can predict the failure and identify patients who request a early aggressive treatment. And at present, we have got a new risk stratification system which has come in the recent this year of EAU guideline, which may change the risk prediction in the coming years and may be useful. But there are a lot of development which may happen because of different factors which can change the outcome, like the new test which is available. Thank you very much.
Thank you, Dr. Ginil, for explaining beautifully about the risk stratification, which is very important for both progressive patient as well as to decide the treatment. Now, the second topic by Dr. Raghavan. Dr. Raghavan is not available here because of personal reasons. I'm going to share his video presentation. Can you see his video?
Yes.
Thank you so much for the opportunity that was given to me to present about this topic today. I have been asked to talk about the dosing schedule for intravesical Bcg. So the indication for Bcg is either high-risk tumor or intermediate-risk tumor, which has recurrent tumor without previous chemotherapy, or recurrent tumor with the previous chemotherapy itself. So the predominant reason for using Bcg is high-risk tumor. But the strategies of Bcg is highly discussed. It depends upon what is the timing to do, duration, schedule, dose, technique. There are many, many papers on this. Now, the first question, when to give intravesical Bcg installation after TURBT? The optimal timing is after 2 weeks, at between 2 and 4 weeks, because you want the time to epithelialization to complete. If you start giving Bcg before that, patients may develop Bcg cystitis. How long to give? The standard protocol that almost all of us in the world follow is Donald Lamb's protocol, which is to be given for 3 years. The standard induction 6 weekly induction with maintenance 3 weekly installation at 3, 6, 12, 18, 24, 30 and 36 months. And we know very clearly the recurrence-free survival is much better when the patient is put on maintenance Bcg rather than just induction. And that was the final results of the EORTC GU cancer group, which clearly showed that in patients with intermediate and high-risk disease, 1 dose versus a full dose at 1 year and 3 year maintenance. For intermediate risk patients, can be given 1 year therapy, but high-risk patients should always be given 3 years therapy. The optimal protocol that we use is the standard protocol, which each of them having a cystoscopy before the Bcg, wait for a week or 2, then they start the Bcg installation. It is something that almost all of us follow. For the intermediate risk non-muscle invasive bladder cancer, induction at once a week for 6 weeks and maintenance for up to 1 year might be sufficient, but it may not be applicable for high-risk tumor. High-risk tumor is definitely 3 year therapy. The Nimbus trial, which was comparing the reduced Bcg schedule versus the standard Bcg schedule in a properly randomized controlled trial, showed that the induction and maintenance at 1 week, 2 weeks and 6 weeks, and maintenance was 3, 6 and 12, a total of 9 installation. It sadly did not show the results be comparable. The reduced frequency arm was inferior compared to the standard frequency and therefore cannot be recommended for standard therapy. What is the optimal dose of Bcg? The conventional Bcg is a Danish strain, which is 120 milligram. Currently, most of us are using 80 milligram and most of us are using Moscow strain. The standard way of dosing is measured with the coliforming units. The effective dose is about 10 to the power of 8 to 10 to the power of 9 coliforming units. But we have to be very careful that there will be variation in strain and from time to time about how many cultures it has gone through as well. This is the Onco Bcg, is the one
Dr.
which we are
Raghu,
using currently.
these slides are not moving
in India.
Raghu, can you please
Now,
check?
when we compare low dose versus standard dose Bcg,
Yeah,
then
there is only
you
audio
have to
working.
see this chart,
Yes, you
especially
can
look
pause
at the forest
it and
plot.
adjust it.
You'll find that the majority
I
of
think it is
the
running in my this one. I don't know in others.
Yeah, but we are not seeing any slides. It is just audio which we are listening.
Dose, as you could see. But
It's a
the forest
recorded
plot is
video.
slightly
This is what I have right now.
Okay, fine. Okay.
the right, favoring the standard dose. Whereas the side effects are always favoring towards the low dose. So we have to balance the between getting efficacious result versus the side effects that the patients will face. This is a very good paper from Sanjay Gandhi Institute, which compared 120, 80, and 40 milligram, and one could see that almost always 80 milligram seems to be the best dosing schedule in terms of efficacy and side effects. The side effects obviously is slightly higher in 120 compared to 80. So 80 seems to be a compromise that most of us have achieved now. Does low dose reduce the side effects? Yes, but the low dose is not effective in high-risk tumors, and vast majority of us are dealing with high-risk disease. What is the optimal technique of administration? Restrict the fluid, diuretics, coffee before installation. Patient should void urine before installation. The urine should be inspected for hematuria, and the dipstick should be done. Routine screening and antibiotic prophylaxis is not recommended. However, I should confess that I do because I have had more than once patient going into cystitis, and therefore I have to stop the BCG therapy. And the reconstitution and preparation, which any of the PG students will know, is a standard protocol. A 8-French infant feeding tube is used. Atraumatic catheterization is done. Empty the residual, watch for hematuria, and give it under gravity, and then keep the patient with a dwell time of 2 hours. The patient doesn't need to have turning, but inevitably I tell them to turn around if possible, and inevitably they will turn because they get very bored lying around. If antibiotic is given, a quinolone is given post-installation, antispasmodics and antipyretics are given, and patient should be given a contact number to report back if they have any issues. This is the LAMPS protocol, which was in the pyramid which you saw before. It is the same thing here. Now, optimal intravesical BCG strategies translate into optimal treatment outcomes in high-risk and intermediate-risk disease. My take-home message is 80 milligrams seems to be the good compromise in terms of dosing efficacy and side effect profile. I still prefer to have the standard therapy of LAMPS protocol. I do not give one-year therapy. Almost many of my patients reach up to 1.5 years, after which they find it difficult to take through up to 3 years. Almost I managed to give to 1.5 to 2 years of therapy, after which vast majority of the patients stop the treatment. This is my experience. Thank you so much.
Raghu,
That is
I think
about Raghu's
slide did not.
presentation. Yes, sir.
Yeah, at all. I don't know if we have time. You can run this presentation later on also. But right now we will move on. And shall I invite now?
Yes,
Raghu?
sir. Please, sir.
Yeah.
Please go ahead.
Yeah, we will move on to next topic, and it is none other than Dr. Badrinath Koneti. He is very well known all over the world, not only in India. And he has been, he was chairman in Minneapolis, which I have gone to the place, but now he's moved to Chicago. And he has been very active in Indian urology society, also to other places like ours and Raghu's and other like Nadiad and everywhere. and he's going to speak is how to prevent and manage the BCG toxicity. Badri, please take over.
Yeah, thank you very much. Sudhir, I'm just going to share the screen here in a second. Thank you very much, Sudhir and Raghu and the Indian Institute of Urology and everybody else who's on the call. Wonderful to see you. It's hard to not have in-person meetings, but at least we can connect this way. And thank you for continuing to organize these and make us all be connected to one another. I just wanted to go spend the next 10 minutes or so going over preventing and managing BCG toxicity. We just heard a really nice talk from Dr. Raghavan on the use of BCG, and he alluded to some of the issues with BCG, and I'll maybe go over that a little bit more. So one thing for us to keep in mind, and I'm sure you're all well aware of this, is BCG is much more toxic than intravesical chemotherapy, because intravesical chemotherapy has local toxicity, but less, if any, systemic toxicity. This is a older study that had a direct comparison of BCG versus epirubicin in terms of toxicity. It's one of the few studies that did a head-to-head comparison of side effects between the two treatments, chemotherapy versus immunotherapy intravesically given. And as you can see, the side effects from BCG therapy typically are much higher and much broader in range compared to intravesical chemotherapy. And this is really across the board. One other interesting thing to remember, the type of BCG or the strain of BCG used does not seem to relate to the type of toxicity. All strains seem to have similar range and severity of side effects. This is a comparison between patients who got BCG interferon and BCG. And the reason I'm showing these data from Mike O'Donnell, which he compared to data from Don Lamb, is to show that if you add some things to BCG, such as interferon, which allows you to slightly reduce the dose of BCG given, that can have a significant impact on the side effects of BCG itself. So there are ways that you can use combination therapies to reduce some of these side effects and also the range of side effects. But one thing to also keep in mind is the toxicity from BCG can be multivariate. It can be very strange sometimes, and it's important for us to be alert to all the different ways in which side effects can manifest. And I'm sure many of you have seen at least some of these different manifestations of BCG toxicity. You can have abscesses, you can get arthritis. So I've had patients who develop severe arthritis while on BCG therapy, and you stop it and it goes away. Infected aneurysm, so patients who already have a pre-existing aneurysms can get BCG infection of the aneurysm. There have been patients with retrobulbar granulomas. Of course, miliary lung infection is quite well documented. Hepatitis can occur. AV fistulae have been observed. Delayed bladder ulcers that almost look like Hunner's ulcers can occur. And I had at least one patient who needed a cystectomy just because of the intractable interstitial cystitis-like symptoms following multiple doses of BCG that resulted in the bladder being removed. Myocardic aneurysms can occur. One thing that the data do seem to show is that patients who have prosthetics, whether it's a heart valve or whether it's a joint, do not somehow seem to get seeded with BCG. So at least that's not been reported unless any of you know of those. I have not come across, thankfully, any patients who had that sort of a side effect. Now, obviously, there's a range of side effects that can occur from BCG, and I'll go through some of those and the potential management options for those. The most common side effect of BCG, as we all are well aware, is a persistent irritative voiding symptoms. Lots of urgency, frequency, burning, sometimes really gross hematuria. Typically doesn't occur after the first installation. You need the immune priming to occur. So it's usually the second or third installation when you start seeing this. And it correlates really nicely with the uptick in the cytokine production in the urine too. So it clearly is immune-related response. And there have been various mitigating strategies that have been propounded. One of them is the use of INH, 300 milligrams daily. And of course, you have to give pyridoxine B6 along with that, just to make sure there's no deficiency in that. and that will increase the side effects. You could also consider fluoroquinolones given at the time and for 12 and 24 hours after the installation to prevent some of the side effects, and I'll go over some of those data later on. And in this case, you can also, the strategy of giving fluoroquinolones along INH is to really prevent INH resistance for the mycobacterium that's being installed into the bladder. You can also hold further BCG and delay the interval. You can go up to 1 to 2 weeks. I think most of the in vitro data suggest that if you delay up to 2 weeks or have an interval up to 2 weeks between installations, you can still get the same overall results in immune response. But delays beyond 2 weeks may not be ideal. That's why we'll see most clinical protocols with BCG have a plus minus 1 week and maximum of 2 weeks, but I trend not to delay 2 weeks. And if you do have to go beyond 2 or 3 or 4 weeks, then you almost have to re-induce these patients. You can also start the INH 1 day prior to each BCG installation and continue it for 3 days. So you're only giving the INH around the time of the BCG installation and not prolonged throughout the entire 6-week period. Of course, some patients, the toxicity can be systemic symptoms manifested typically by fever. And this is luckily a very small subset of patients, only about 3% or so, but they can present with a very high fever of over 102.5 or 103. And oftentimes, if it's just a fever within the 24 to 48 hour period, we'll give them a dose of Tylenol or Motrin and see if that will allow them to defervesce. But if the fever persists beyond 48 hours, then we assume that it's a BCG toxicity-related fever. And you may need to bring them into the hospital and start them on antituberculous therapy with the INH and rifampin, along with pyridoxine. And in some cases, as I mentioned before, adding a fluoroquinolone, like Cipro, for example, will allow you to mitigate against the reduced efficacy of INH that can occur sometimes and avoid the INH resistance. An even smaller subset of patients can manifest as Bcg sepsis. This is typically associated with intravascular absorption of Bcg that's been instilled. I have actually seen this occur right in front of my eyes in a patient that we were instilling upper tract Bcg into. I mean, the blood pressure just kept going down, and the patient crashed, and we had to rush the patient into the ICU and put them on pressors because this can happen in a fairly rapid fashion. So if you are instilling upper tract Bcg, you have to be a little more careful about this, but at least in my experience. But it can also occur with intravesical installation. And in these patients, you have to immediately start them on INH or rifampin and ethambutol. Cycloserine has been routinely used once a day. That's because it gives you the quickest action. It can achieve peak concentrations within 3 to 4 hours. And this is typically a board question for us too, as to what else you need to add, because INH, rifampin, and ethambutol will take a little while to kick in. Whereas in this kind of sepsis situation, you need to add another drug. And if you want to increase the broad spectrum coverage, adding a fluoroquinolone or aminoglycoside will also help. Now, if these measures don't help and the patient is still quite sick and blood pressure is not coming up or the florid sepsis picture still persists, you could add prednisone, 40 milligrams a day. This treats really the hypersensitivity reaction that is underlying all of these symptoms. So that can be continued for about a week until the patient gets better. Now, the 3-drug regimen, INH, rifampin, and ethambutol, needs to be continued for 3 to 6 months, which is the traditional antituberculous therapy. And of course, these patients are not going to get BCG anymore. The interesting thing is all the new combinations that are coming out with just the mycobacterial cell wall and so forth, you do not see any of these side effects. So it appears that you need to have the intact organism to be able to create some of these more severe, to be able to have some of these more severe side effects. Now, there are other strategies you can use to try to avoid or reduce the local toxicity of BCG installation. And this is also true for intravesical chemotherapy. So Jean Palou has published a paper, a very small series of maybe about 16 patients or so. And many of them also did get oral nonsteroidals and anticholinergics. But what he does is he takes a liter of distilled water and mixes nitrofurantoin, tetracycline, and some steroid into it. and then instills this small amount of the solution into the bladder and drains it, and then instills the intravesical therapy, whether it's chemo or immunotherapy. And that has significantly reduced the incidence of nocturia and pain in these patients. Now, I'll again caution us that this may not be universal. It's in a small subset of patients, but does seem to help in some of these patients, at least in his experience. I have myself not done this, but in some cases you can use just a solution of lidocaine and some bicarb that you can instill just as a local anesthetic. That can make it more tolerant for some patients. Now, in order to prevent sepsis, one of the key things, and Dr. Raghavan also really stressed upon this, we have to be very meticulous in how we instill BCG and when we instill BCG to be able to avoid some of these more severe side effects. You typically wait at least, my practice, I at least wait 2 weeks post biopsy or TUR before I will instill BCG. 1 week is too short, 2 weeks is ideal, and 3 weeks is okay as well. I don't think you're going to risk anything else. And this becomes an issue sometimes in patients who have high-grade T1 disease. You have to wait 2 or 3 weeks anyways, and then go back in and re-resect, and then wait another 3 weeks after that to instill the BCG because you have re-resected the same area twice. Now, and of course, patients should not have any evidence of gross hematuria, and you want to make sure they have no UTI. We just dip test the urine in the clinic every time. Sterile bacteriuria is okay. I don't think that itself is a contraindication for BCG installation. Catheterization has to be atraumatic, and obviously sterile drug preparation and handling are critical. And you also want to monitor the patient and have a prompt response to the patient's condition. At least in the United States, increasingly what we have started doing is instilling BCG in infusion centers where they also do systemic chemotherapy. And some of these nurses are quite well able to manage some of the side effects of BCG because they instill all sorts of other intravenous chemotherapy and are quite capable of taking care of fairly sick patients. So when you're doing this in a urology clinic, not all urology nurses may be well versed with treating patients who are undergoing or manifesting sepsis or some serious side effect from BCG. Now, a couple of words about urinalysis. Typically, everybody gets a urinalysis before instilling BCG. That is not really mandated by any of the guidelines. And also, we could overinterpret the results of such urinalysis. If you just have white cells in the urine, it's okay, especially if it's during BCG therapy. And actually, there is data suggesting that having an increase in white cell count in the urine during BCG therapy may actually correlate with a positive response to BCG. So that in and of itself is not a bad thing. And pyuria can occur in about 28% of these patients and has a very low positive predictive value for subsequent UTI post-installation. And actually, even presence of bacteriuria has a very low positive predictive value, under 1%, for occurrence of UTI post-BCG. And there's a nice study which suggests that only 9% of patients who had bacteriuria before BCG installation and got BCG installation regardless went on to have UTI subsequently. So really, we may not need to take bacteriuria and pyuria as seriously as we sometimes may during BCG installation. I think the likelihood of UTI post-BCG in and of itself is also fairly low, probably because BCG is really creating such a robust immune response in the bladder that much of the bacteria are probably going to get destroyed by that immune response. The other thing that people have studied a lot is how do you mitigate some of these local irritative voiding symptoms, which are most bothersome to patients. As I mentioned before, people have tried to use INH in different methods, either just during around each installation or prolonged. It does cause increased LFTs, but there's at least one randomized trial suggesting it does not really do much more than that and is not very helpful. So I typically don't routinely use INH. I have used fluoroquinolones routinely as part of the protocol. There's at least 2 studies now and maybe a third one, all of which they've studied ofloxacin, prorifloxacin, and even gadifloxacin in the same sense. Ofloxacin given routinely 6 hours and 18 hours after installation of BCG can really help reduce the irritative voiding symptoms. Of course, the other drugs, you have to use different dosages. Oxybutynin has been used in a randomized trial fashion. around the time of BCG installation is not shown to be of any benefit. One word about BCG dose reduction. I know Dr. Raghavan mentioned the Nimbus trial and the lack of comparable efficacy of full dose versus reduced dose BCG, and that is correct. But in case you have a patient who's got severe side effects and is not able to tolerate full dose BCG, I think there is still value to trying to reduce dose BCG and try BCG, because it does still have benefit in inducing cytokines and creating local response. Yes, it is not as good as full dose, but it is not useless. And in a patient who, the other option is to not give BCG, you're better off trying to reduce dose. And you can go all the way up to 1/100 and still have the same efficacy as maybe a lower dose reduction, such as 1/2 or 1/3. Now, the other thing you can do is reduce the dwell time to 1 hour. And there is at least one study, a small randomized phase 2 study that showed that whether you use 2 hours or 1 hour, the outcome is the same. So the idea that you need to have it in there for 2 hours is not being robustly tested. This is only one study that's a phase 2. I think Stuhler's group did this a while ago and published it in BJUI. But I think that's only a strategy you want to use in somebody who's not able to tolerate prolonged intravesical BCG. And can we use BCG in patients with prosthetics? As I mentioned earlier, yes, you certainly can. And at least so far as we know, and this is data from a 1,000-patient study that Mike O'Donnell led, which shows that there is no increased infection or seeding of prosthetics. How about in patients with transplanted organs? It does, I think it can be used safely. But the efficacy is questionable. It does not seem to be as effective because obviously they're on the anti-rejection medications. There's one study with 45 patients from Sloan Kettering in whom 12 patients had transplants, liver and kidney mostly. And only 3 of those patients responded, whereas in the same study, 33 of the other patients actually had steroids and other immunosuppressive medications, and 32 of the 33 responded to intravesical BCG. So it can be used in transplants, but perhaps it's much more efficacious in those with other types of immunosuppression, such as steroids that are being given for various reasons. And in conclusion, we should remember that BCG is a very highly effective treatment. It does have a higher incidence side effects compared to intravesical chemotherapy. Some fatalities even have been reported. There have been about 12 deaths that have been reported worldwide in the literature. You have to be alert for unusual systemic side effects, and meticulous attention to technique and timing of installation is important. And dose reduction can help in reducing some of these symptoms and has to be kept in mind if your alternative is to just stop BCG altogether. Adjuvant therapy at installation can help and may be useful to make it part of your protocol. And serious side effects will require prolonged antituberculous therapy. Thank you again for the opportunity to talk to you all. Appreciate it.
Thank you, Dr. Badri sir, for an insightful talk on BCG toxicity, how to prevent and manage it. Now we will move on to the next topic, that is BCG failure. To understand this BCG failure, what are the options and what are the outcomes of this BCG failure after treatment? So to talk on this, we have Professor Christopher Wade, who is a well-known uro-oncologist and is the Director of Urological Oncology at Cleveland Clinic, USA. I welcome you, sir, and over to you.
Great. Thank you very much for this opportunity to speak. I wish I was there in India with you. I have not been to India yet, and I have many colleagues who I really admire and respect and appreciate the contribution to urology that's come from India. So I've been given this invitation to speak about the management of BCG failure. Let's see. I'm speaking to you from Cleveland, from the Glickman Urologic Institute. This is our 100-year anniversary, so we're excited about that. Past 100 years of development and innovation at Cleveland Clinic, and certainly, if any time you want to come visit us here, I put my contact information in the chat, and I would be happy to host you here if you're interested in doing research or other opportunities. Please get in touch with me. So I want to just start with the definition of BCG failure. And then the way I see it, there are kind of 3 ways to treat BCG failure. 1 is surgical options, 2 intravesical options, and 3 systemic therapy options. We're going to talk about these. I'm going to defer most of the surgical options to Manu, who's going to speak after me. But the definition, this is from the recently updated and referred to guidelines by the EAU. But really, this is if you have any T1 high grade after induction BCG, if you have persistent TA high grade or CIS after 2 courses of induction, or if you have a high-grade tumor that appears during maintenance. These are kind of the people that are grouped into the refractory group. There are other definitions that are somewhat similar, and some of these patients may fall into this same group and same treatment paradigm, but relapsing is when they really have an initial response, but then recur. If the recurrence is late after an initial response and maintenance, then reinduction probably makes sense. But if they recur early after initial response, that's termed a BCG unresponsive tumor, and they may also benefit from what we're going to talk about here. And then, of course, BCG intolerance, as Dr. Canetti referred to, there's some people that have some severe side effects and causes discontinuation of the treatment. Well, what do we know about this BCG refractory group of patients? Well, this is a problem, and these patients are at significant risk for progression. They have very high risks of recurrence. And there was a large multi-institutional cystectomy registry in the United States, and they kind of looked at all of those that had what was believed to be CIS only and refractory non-muscle invasive bladder cancer. And when they went to cystectomy, a quarter of them already had muscle invasive disease, and 6% of them had lymph node metastasis. So we know that this is a high-risk group, and they shouldn't be treated lightly. We need to treat them because they're very at high risk for progression or recurrence. And so my first choice, if there's a BCG failure and their surgical candidate, is go on to radical cystectomy. And we'll hear in the next talk why that makes sense. But this is really the best oncologic option. But of course, maybe not all patients are great candidates for this, or maybe are very resistant to having their bladder removed. And so let's talk about what are the options we have in terms of intravesical options for BCG failure. Well, as you can see from this list, there's a long list of other sorts of salvage options. This group as a whole suffers from a similar problem. Either one, the studies are small or retrospective, or two, the response rates were marginal, or maybe three, they were good initially but not very durable. And a lot of these things have been studied. Some of them have shown some progress, but most of them really haven't shown promise to the point where we're just satisfied and say, hey, we have a solution for these patients with BCG refractory bladder cancer. And that is why early cystectomy has really remained the best oncologic treatment, because most of these end up either not responding well or failing. In the United States, only valrubicin on this group is approved for this indication, but I have used, and probably many of you have used, several of these options and had modest results, but the majority of people who get these will either recur or progress. So we have some space for other innovation here. There are device-assisted installations. I don't have any personal experience with these. These are not widely available in the practice locations I've been in, and partially because it suffers from some of the same challenges from the past slide. The studies are small, or not that effective, or maybe not very durable. And so these device-assisted installations still need a little bit more either study or need to show a little bit more efficacy before we can really move them into this space on a large scale. But we do have something exciting, and this was published just last year, and this is nadofaragene firadenovec. This, for those of you who have not seen this compound yet, also known as the trade name in the United States is enstiladrin, is a non-replicating adenovirus that has INF alpha 2B loaded into it, along with a excipient polyamide named SIM3. These are given simultaneously intravesically, and these adenovirus vectors are uptaken by the urothelial cells. They go into the nucleus and they increase transcription of the INF2B protein eventually gets made, and then this goes and causes a complex number of immune-mediated and cytotoxic mechanisms that have been shown to be effective against cancer, first in animal models and then in early phase trials, and now most recently in this trial that was just published in Lancet Oncology just a few months ago in a larger multi-institutional trial. So this is the design of the phase 3 trial to which I just referred. The treatment delivery is really quite straightforward. It's really, one dose of installation every 3 months at month 1, 4, 7, 10, and 12. So really 5 doses delivered over that first year. When Dr. Kennedy and I were at University of Minnesota, we had this trial open. It was fairly easy to deliver, and patients tolerated it really quite well. And it's less of a treatment burden, for example, than induction BCG with the 6 weekly doses and a more intense maintenance schedule. These are the baseline characteristics of the participants in the study. You can see the average age was 70, 71. Unfortunately, most of the patients are male and white, so we still have yet to know how well this applies to other ethnic groups and to how well it will function in women. And then you can also see that about 2/3 of the population had CIS and about 1/3 had papillary disease. But what were the results? Well, they were really quite good and quite exciting at 3 months, whereas a lot of those salvage intravesical therapies that I showed a few slides back, the 3-month high-grade relapse-free survival was on the order of 10 to 20%. In this study, it was almost 60% had no evidence of high-grade disease at 3 months. And though it does drop down, as you can see, over the ensuing follow-up, still a significant number, of more than 30%, were still disease-free at 12 months. And you can also see that the patients with CIS did a little worse than those with just papillary disease, but overall, there was still a good response. And notably, only 5% progressed to muscle-invasive bladder cancer. So really exciting. Here you can see again the high-grade relapse-free survival on Kaplan-Meier curves. And then just recently, Vikram Narayan, who was one of our residents at University of Minnesota, now is a faculty member at Emory, where he's going to be a superstar. He just recently presented this at the SUO meeting a few months ago, that the cystectomy-free survival was also very good. Only 26% went on to get a cystectomy. The median time for that delay was about 8.5 months. And you can see the Kaplan-Meier cystectomy-free survival curve showing even at 24 to 30 months, the vast majority still have not undergone cystectomy. So really an exciting option here. And this part is also exciting, is that despite having such a good efficacy in fighting off the cancer in this salvage situation, it was tolerated very well. Only 3% had grade 3 or 4 drug-related adverse events, and only about 2% stopped treatment due to adverse events. To see that you can really see that it was tolerated well, and no treatment-related deaths. So I think this is really promising. It has not been FDA approved yet, not because the efficacy data is in doubt, but because there are a few production details that need to be finalized to meet the FDA's requirements, but a really exciting option. So let's move on now to systemic options for BCG failure. We didn't have anything here forever that would work, and just recently, a year and a half ago or so, pembrolizumab, a PD-1 inhibitor, was FDA approved. And I'll just briefly go through some of the data that led to this. The initial rationale as to why this might work was that it was noted that BCG treatment can induce PD-L1 expression. And you can see here in these graphs, these are in dendritic cells and macrophages. Over in the black columns, these were unstimulated cells, and then they measured PD-L1 expression after exposure to BCG. And as you can see, 24 and 48 hours later, the expression really went up in macrophages and dendritic cells. Here's a pathologic slide with the PD-L1 staining kind of that lightish brown color. There's a before and see and after, and you can see that there's significantly increased BCG PD-L1 expression with BCG. And the thought is, maybe you could get a synergistic effect by then throwing a checkpoint inhibitor either in simultaneously with BCG treatment or after BCG treatment. And that led to the Keynote 57 trial, which was a phase 2 trial. This had 100 patients enrolled, and they had a 40% complete response rate at 3 months. So not quite as good as the Natogene, but still better than most of the existing salvage therapies. And that response was durable for the majority of responders at 1 year. As follow-up has gone on, 3 have progressed to muscle-invasive bladder cancer. It was also well tolerated by most. It's interesting, they have not published their data in a peer-reviewed setting yet. They've only been presented at meetings, and we're awaiting kind of the peer-reviewed publication. But from their presentations, you can see this Kaplan-Meier curve for complete response, the durability of complete response. Again, in that group that responds well, the durability seems to last at least in the early follow-up. The adverse events, though, for pembrolizumab were a little bit higher than we saw with the Intravesicle and Stilodrin. 11% discontinued treatment due to adverse events. And I'll just remind you, it was only 1% for the Stilodrin, and 10% with grade 3 or 4 AEs and 1 treatment-related death. But nevertheless, this has prompted a lot of excitement for this type of mechanism. And so there are lots of trials that are ongoing right now using atezolizumab, another checkpoint inhibitor, and then several that are combined with BCG and checkpoint inhibition. And also exciting from the urologic standpoint, there are also a couple of these immunotherapy drugs that are being tried in the intravesical setting. So in conclusion, when you have BCG refractory bladder cancer, what are your options? I think surgical options are still a great option, so I'm looking forward to hearing about that. Checkpoint inhibition, I really think, is going to change the management of non-muscle invasive bladder cancer. It will be interesting to see what happens in all of these other ongoing studies. And then I would just say, of these newer agents, I'm really excited about the nadofaragene, because I think it has a better efficacy and a lower safety protocol. And I also like it because it keeps the management of these patients with urologists where I think it should be. Thank you very much for the invitation.
Thank you, Dr. Chris. It was a great talk and very good learning also. And the next talk is by Dr. Manoharan. I think most of us know him. He works in Miami and a very good friend and very helpful person. And his last name is Murugesan. I don't know how many of North Indian know about Murugesan, but they should Google it, the last name. Because when I went to South for my urology training in Vellore, I came to know that Karthik is the god which is very popular in South, while in North we just used to ignore him because we all knew about Ganesha was the son of Shiva. So this Murugesan stands for Karthik. But just to go for the topic is role selection of patients and results of early cystectomy by Manoharan. Mano, please take over.
Thank you, thank you for the introduction. What I'm going to do is that I record the video for streaming purposes. I'm going to run it for a minute to make sure that the system works, so that we'll know what was the problem with Raghavan. And if the system doesn't work, certainly I will go ahead and do the talk in a normal way. And so let's see. Whether sharing the screen, and I'm just going to play that.
Can't hear your voice, Manu.
I can't hear the voice either.
No, there's no sound. It's very slow. Can't appreciate.
So I just checked it to see whether it works. And do you want me to let me do the regular talk? I just only testing.
Yeah.
Let me do the proper talk. Okay.
Yeah.
Again, today, this evening, I'm going to talk about the role of early cystectomy in non-muscle invasive bladder cancer. And as you know, that we use the term early cystectomy when we treat bladder cancer. However, in the field of urological oncology, when you do a prostatectomy for a T1 disease, we do not call that as a early prostatectomy. For kidneys, again, we don't do that. However, when we are dealing a life-threatening disease such as bladder cancer, we want to use the term early cystectomy. But when you look at the prostate cancer, in year 2015, 85% of the patients who underwent prostatectomy were T1 disease, and the survival figures are 95%. But we went ahead and did a radical prostatectomy. We did not call them early or delayed. When you look at other diseases, such as kidney cancer, which is 75% of T1 disease at the time, and with a survival figure of 85%. Whereas if you look at the CA database in 2000 and 2005, only 21% of the patients underwent radical cystectomy for a non-muscle invasive condition. But as you know, the overall survival for radical cystectomy patients is only 55%. But still, we call that as the early cystectomy, and we're reluctant to offer that to the patients. So some of them use different terms, like optimal cystectomy, primary cystectomy, and a timely cystectomy. So with this background, we mostly do what is called as a early cystectomy for patients at presentation only when they are with a T1 disease with a high grade with certain features, which we'll discuss in a minute, but more commonly in patients who had Bcg failure and they're patients with a T1 disease. Just a second. Can you hear me all right?
Yes, you can share your video and you can speak.
I think, no, I'm just doing the slides, you're able to see the slides, right?
Yes, yes.
No, we can't see your slide right now.
Really?
Yeah. There's no slide.
Oh my God, I thought I was looking at the slides,
No.
My God. Okay. Sorry about that. I think there's this problem with the system here.
If you want to share.
You need to open. Yeah. Now something is coming. Yeah, it is coming now.
Oh God, I thought I was under the impression the slides were going on. Okay. Can you see the slides now or no?
Yes.
Yeah, great. Okay. So I'll continue the talk if it's okay with you. I apologize for it. I didn't realize it. Please stop me if things are not going well. Why do we want to do a early cystectomy? The main reason is that the surgical outcome or oncological outcome on patient welfare. If you look at the well-known outcome survival graphs, if you do the cystectomy for a T1 disease, 5-year survival rates are more than 90%. That is very significant. When you do it for T2 disease, it comes down to 75. For T3 disease, it becomes 55%, and for T4 disease is 25%. So you can see a big difference. And when you perform the cystectomy before it becomes muscle invasive, the outcomes are extraordinary compared to the T2 and T3, T4 disease. Other than these things, there are a few other reasons why we can support a early cystectomy. One, if you do the cystectomy for T1 localized disease, obviously you can avoid adjuvant therapy such as chemotherapy. That's a good reason. Secondly, when you're doing a cystectomy for a T1 disease, it somewhat gives you an increased opportunity to preserve the nerve bundles, both men and women, and also higher possibility of performing the ileal neobladder, which allows us to improve the quality of life for the patient. But more importantly, it also significantly reduces the early and late recurrence, and hence you do not need a very extensive follow-up in the long run as the years go by. So these are the reasons why we can support cystectomy. Despite all that, most of us are reluctant, both patient and physician, to perform early cystectomy for non-muscle invasive bladder cancer, mainly because of the quality of life issues, mainly the urinary diversion complications, sexual dysfunction, body image. As all of us know, it is a major complex surgery, and we have a complication rates anywhere between 30 to 60% with a mortality rate of about 3 to 5%. Because of these reasons, many of us patients and doctors are reluctant to offer cystectomy early. We can choose certain patients, but one of the most important reasons is when the patient chooses to have a radical cystectomy for T1 disease, it should be seriously offered to the patient. And as all of us know, that other indications include multiple tumors in the bladder, tumors larger than 3 centimeters, lymphovascular invasion, associated CIS, prostatic urethral involvement. These are all good reasons to consider early cystectomy. Other reasons are when If I'm not able to resect the tumor completely, I would seriously think about offering radical cystectomy yearly. Sometimes the tumors are in difficult locations, such as anterior wall closer to the bladder neck, then I will seriously consider doing cystectomy, diffuse CAS. But there are patients who may not be able to receive BCG, other alternate treatments, on patients with intractable symptoms, and most commonly, when the BCG fails, I will certainly offer yearly cystectomy. We need to think more about so-called T1 high-grade disease and the role of radical cystectomy in this patient in an appropriate time fashion. At present, there is no level 1 evidence suggesting what is the right treatment for T1 high-grade. So most of us rely on expert opinions, some of the publications, and how we interpret the available data and make our own decisions. But as you know, the T1 high-grade disease, as everybody pointed out, it is a biologically aggressive disease, and we should not treat them as a superficial bladder cancer, which we all of us know. Why? Because of the increased propensity for recurrence, progression, particularly metastasis and death, which we want to avoid in a T1 disease. As you know, in T1 high-grade disease, the recurrence rates can range up to 70 to 80% and the progression rate of 30 to 50%. But most important thing to know is that even if you do immediate cystectomy, we lose about 1 in 5 patients following cystectomy due to bladder cancer. So when we are dealing with a high-grade T1, are we really dealing with a high-grade disease which is T1 or it is upstaged? So as you know that when there's a muscle in the specimen, we can get up to 50% upgrading without specimen, and with muscle that can be 30%. But more importantly, there is about 30 to 50% chance of inter-observer variability among the pathologists, which we are trying to resolve with various guidelines. But as one of other speakers pointed out, T1 disease is not always localized. Several studies have shown that the lymph nodes can be positive up to 6 to 16% of the patients, and thinking that this is a benign disease, we can salvage the bladder, you can also compromise the survival of the patient. So we need to remember lymph nodes can be positive and involved in T1 disease as well. And the main thing is to minimize understaging. Every urologist, emphasizes this with a repeat TUR. But when you do a TURBT again for a T1 disease, what happens? There are 3 situations can happen. You can have no tumor or CAS. In those situations, the rate of progression is about 20% at 5 years. When you have a muscle invasive disease, you're going to opt for radical cystectomy or a chemoradiation. But when you have a T1 disease again on a repeat TUR, after a good TUR, you get a T1 again, the progression rate is very high at 80% at 5 years. So this is one of the important prognostic thing you need to remember. If you've done a good TURBT and again you go back again 2 or 3 weeks later, if still disease is still there, you need to always think about possibly early cystectomy. So with this in background, once again, other indications are if you have a variant tumors, particularly many people think about micropapillary, or if you have a lymphovascular invasion, or you have an adjacent CIS, or when you're doing a TURBT, it looks more like a solid rather than papillary. And all these things are additional reasons why you should seriously think about offering yearly cystectomy for these patients. But bladder preservation should be offered to every single patient. What I feel important, I always stress this again and again, is a meaningful patient-physician discussion. You need to give time for the patient to ask questions, etc. Many patients, like if they decide to go for bladder preservation, they always go for a BCG with induction maintenance, which still remains the most effective therapy, but we are getting a lot of new information as Dr. White spoke earlier. But is BCG effective in every single patient? Probably not. There is an issues with tolerability and toxicity. The progression rates are controversial, but there is a significant early and late failure rates, and you need to follow up the patients. And we do not have a very useful additional treatments at this point of time, even though in future we might get that. And even though there's no scientific basis, many of us use the rule of 3. When you have a T1 high-grade disease and 1/3 of the patients may survive well without intact bladder, so are we doing unnecessary cystectomy in those patients? 1/3 might survive without their bladder, they can undergo cystectomy. But remember, we also lose about 25 to 30% of patients with non-muscle invasive cancer by them cystectomy. If you look at the BCG thing, over the year 2090s, 43% of the patients recurred, about 25 patients did progress. So this number has been stable over the years. So we need to remember that the 1/3 of the patient will progress. It can be life-threatening, or we might lose the patients. There are a couple of studies I want to go from year 2000, from May, and they looked into 230 patients. They divided them into 3 different groups. One, at the time they used the word superficial TCC, underwent immediate cystectomy, superficial TCC, BCG, and then progressed, then had a cystectomy. On patients who had muscle invasive disease after BCG and had cystectomy. When you look at the numbers, patients who underwent a yearly cystectomy, the progression-free survival was 77%, which is very good, and also overall survival was 63%. Compared to group 2 and group 3, both of them are roughly about 50% progression-free survival and overall survival of only 50%. So you can see that there is more than 25% advantage in performing a yearly cystectomy compared to delayed cystectomy. In another study from MSK, they looked at 307 patients. They used a different definitions. Yearly cystectomy means done within 2 years of diagnosis. Delayed cystectomy is done more than 2 years, and in between those patients underwent BCG, TURBT, and then they recurred and had cystectomy done. When you look at the outcome in these patients, if you look at all comers, when you do the cystectomy early on, they certainly did much better compared to a delayed cystectomy done after 2 years. And obviously, when they had a superficial recurrences, and then you do a cystectomy, they did much better compared to when you allow the disease to progress into muscle invasion. If you look at the numbers, if you do the cystectomy yearly, the survival figures are 92% compared to 56% in late RC. Similarly, recurrent muscle invasive TCC after BCG, if you still do the cystectomy within 2 years of diagnosis, not from the progression, it's 41% survival compared to late radical cystectomy, 18%. So 2 things are important. One is pathological stage, but more importantly, the timing of the radical cystectomy. So we should always think like a cystectomy and then consider not to do it, rather than refusing to consider cystectomy upfront, because it's a biologically aggressive disease and BCG does not reliably prevent progression. And at present, we do not have a very good prognostic markers to tell us who's going to progress or not. And certainly, a non-muscle invasive cancer deserves a better fate compared to muscle invasive cancer, and we should not allow the patient to die when they are diagnosed with non-muscle invasive cancer. That is what should be our philosophy. So the aim of the cystectomy should prevent death from metastatic cancer, and it makes sense to consider performing cystectomy rather than after there's a stage progression to muscle invasion. At this point of time, our philosophy is that we are trying to avoid unnecessary cystectomy in 30%, but at the same time, we are willing to lose 20 to 25% of patients dying from the disease. That seems to be a current philosophy. We need to seriously think about it, have a good discussion, then make a decision, then it's fine. And so the question we should be asking is not, is a cystectomy necessary? But the question we should be asking is, when is less than cystectomy is sufficient and adequate for the patient's welfare, cancer control, and survival? We always put the quality of life as a reason for not doing a cystectomy, but the most important factor affecting the quality of life is life itself. If you don't have life, there is no quality. So meaningful discussion, meaningful consideration of all the factors, seriously giving a thought about cystectomy, then making a choice is the best way to go, in my view. Thank you very much for your time. I appreciate it.
Thank you, Dr. Mano, for an enlightening talk on early cystectomy, its implications. So with these 5 talks, we have understood how to manage non-muscle invasive bladder cancer. Is it applicable in Indian scenario? So to talk on this, we have Dr. Gagan Prakash, who is a professor of urological oncology at Tata Memorial Hospital. So he would speak on Indian data on intravesical therapy, what we know and what we should. Over to you, Dr. Gagan.
Thank you, Dr. Raghunath. Hope my slides are seen.
Yes, yes.
Good evening, everybody. Thank you, USI and ISU, for this opportunity. And thank you, Dr. Raghunath, for this topic, which actually made me much work harder than I would do for other talks. So, let's start with these notes from a patient way back in early 80s. This is from a patient who was treated in Tata Memorial Hospital. If you could see, this was a non-muscle invasive patient being offered thiotepa, mitomycin C, adriamycin. And then sometime in 1987, this is when he received BCG installation. This was the first patient in India to receive BCG installation, and he's still coming up for a follow-up, and that's how I have these notes. 1994, Dr. Tongaonkar, Dr. Jain Kulkarni, and Dr. Murli Kamath from Tata Memorial Hospital actually presented their first series from India on Intravesicle Bcg. And this was actually accompanied by an editorial by Donald Lamb himself in the Journal of Urology. In the next 5 years, there were more and more series, another 2 series from Tata Memorial, one in the BJI from by Dr. Jain Kulkarni, and in IJC by Dr. Tongaonkar, talking about the outcomes of BCG. And at the same time, there were a couple of series which came from Delhi about combining BCG with immunotherapy in Indian patients. More recently, Dr. Jinil and the team from Amrita presented a more contemporary series where they actually compared the outcomes in patients who received induction and maintenance both. And surprisingly, although we know that there's level 1 evidence for maintenance therapy, in Indian patients, it did not seem that maintenance was making a huge difference. And they also highlighted a local toxicity rate of around 70%. The study which Dr. Rajiv Sood was talking about, which was published just a few months ago, which was done in collaboration with the Serum Institute using the Moscow strain, which all of us are using currently, said that probably 80 milligrams in terms of efficacy is the same. This study said that there's not much of toxicity with the Moscow strain. However, if we look at the literature for India, we see that there are more and more publications about toxicity than talking about efficacy. I mean, the whole spectrum we've been described here, right, from penile tuberculosis to renal granulomas to patients going blind to nephrotic syndrome. I must compliment this study from Jabalpur Medical College, actually, which a very contemporary series, and they have compartmentalized the toxicity into very clinically relevant terms. So again, the same as Dr. Jinil's series, 70% of patients in this series had toxicity, 22% of them had mild symptoms, 14% of them required a dose reduction, and 15% of the patients required stoppage of BCG because of toxicity. And a bigger compliment to Dr. Yuvraj and Dr. Vaigankar on actually comparing the Danish and the Moscow strains, very relevant for our population. And thank you, Dr. Santosh, for sharing these numbers. The figures are still under peer review. But what it shows is that the Moscow strain has moderate to severe symptoms in 67% of the patients compared to 48% from the Danish. BCG discontinuation or dose reduction was required in 43% of the patients compared to 25% in Danish. Around 20% of patients require anti-tubercular treatment, and 10% of patients require cystectomy for BCG-related toxicity when we're using the Moscow strain of late. So are we overdosing our patients with 120 milligrams of BCG, using the Moscow strain? So this has been seen earlier using the Danish strain, a couple of good series, one by Dr. M.S. Agarwal from Agra, where they compared 40, 80, and 120 milligrams, found that the efficacy doesn't differ, and the toxicity is more with 120. The same from SGPGI, almost at the same years, 2006 and 2007. Similar findings, toxicity increases, efficacy does not change even when you reduce the dose to 40 milligrams. So what's happening over here? And, we try to do a little detective-giri in this whole thing. My fellow, Dr. Amandeep at Tata, he helped us figure out, and dig out a lot of literature from the West and in India, and seeing all of the pamphlets and the roads which are used across the world. So Danish 1331 is what we've been using earlier. The packet mentions that it has around 8 into 10 to the power of 8 colony forming units, which is supposedly, the adequate dose when you see the literature in terms of colony forming units. What we're using right now in India is the Moscow strain, which strangely is not mentioned in the pamphlet. It just says that there is 1 to 19.2, a huge, variation in the dose into 10 to the power of 8 colony forming units. And by this figure, actually 1 vial of this BCG, which is 40 milligrams, probably should be adequate for our patients. So how is this dose of BCG determined? We all know that it's the colony forming unit, which is more important than the actual dose. If we go further into seeing the evolution of BCG strain, this is kind of interesting. It was almost a century back when actually BCG was, first discovered, 1921, from Mycobacterium bovis. And there were like, various series and refinements of BCG. And if you look at the strains which were used in the West, the Keynote, the Tice, and the Danish strains which we are using are actually the late strains which have gone various series of refinement. But the Russia strain or the Moscow strain which we are using right now is actually one of the early strains which was initially derived, probably, and that is also translating into other findings where we see that the interleukin 8 response to the Moscow strain is far more compared to the Danish strain or compared to the Thai strain. Another interesting study where they've seen all the different strains which have been used and tried to see the response. And what they've concluded is actually the Russian and the Keynote strain, which were evolutionary earlier, as we've just seen, are the most efficacious BCG for both inhibition of cell proliferation and induction of cytokine production. So are we missing something here? So what we understand based on all this information is that a lower colony forming unit of Moscow should produce the same anti-tumor effect as that of Danish. 40 milligram of Moscow contains higher colony forming units than 40 milligrams of Danish. Probably 40 milligrams of Danish and Moscow are not the same, and the same would apply to 120 milligrams. Also, if you see at the various BCG strains which are used across the world, most of them have been using actually 1 vial. Whereas in India, I believe most of us are using 3 or 2 vials, and I think we need to question that. So how do you quantify BCG toxicity in clinical practice? Once we know that there's a problem related to toxicity, we need a tool to kind of quantify them. URTC has a questionnaire called the URTC NM, and there is this questionnaire which was developed by Michael O'Donnell from University of Iowa. The issues are there. This is quite extensive. They've been like between every cycle, every induction, so the patient has to essentially fill up the questionnaire almost 36 times. Just a glimpse of the other publications from India. So they've been, again from Dr. Ginil and the team at Amrita, they found that bladder irrigation with sterile water was as good as mitomycin C. Oral pentosan polysulfate has been used to counter the toxicity. From Lucknow, they've seen the adverse effects of BCG on spermatogenesis and oligospermia. Management of BCG non-responders with gemcitabine has also been seen in Indian patients. From Belgaum, Dr. Nurli and his team has looked at low-grade tumors and their patterns of recurrence and whether they can predict which patients are going to have a worse prognosis. Different regimens like the monthly maintenance instead of the SOG has been seen in India. And there's been actually a lot of translational research as well. And I must compliment the team from SGPJ, Dr. Mandhani and Dr. Anand Kumar. I was surprised to see that there've been actually at least 5 or 6 papers, based on translational research on BCG and intravesical therapy from India. So just to wrap it up, I think what we would want to know is, I think we should have a questionnaire or a tool which helps us actually quantify this toxicity. We would also want to know when to start steroid in our patients, when to start antitubercular treatment, because in India, the TB treatment is actually governed by RNTCP, and we might have to have our own guidelines in these scenarios. What would be the right dose for BCG, whether it is 120, 80, 40, or even lesser for our population when we are using the Moscow strain? And in terms of alternate intravesical therapies, what would be the option, something which can be used across India, something which doesn't require a hypothermic machine or additional equipment? And I would say that it's high time that the Urological Society of India should be Atmanirbhar in finding solutions to our intravesical therapy related issues. Thank you so much.
Thank you, Gagan. It's a great talk, and good to know that what has gone in the country. And with that, I think we will move on to the panel discussion. Raghu, would you like to invite the moderator and panelist?
Yes. Yes, sir. We are running actually behind the schedule by almost 15-20 minutes. So we will move on to the case-based discussion. I would invite Dr. Sanjay Adla. He's a consultant uro-oncologist and robotic surgeon from Apollo Hospital, Hyderabad. He has very interesting cases. So without wasting much time, I invite Dr. Sanjay Adla. Over to you, Dr. Sanjay.
Thank you, USI and ISU for giving me this opportunity. And I've got a panel of 3 international and 3 Indian panel members, Dr. Badrinath sir, Mano sir, and Dr. Wait. And for the Indian, Dr. Ginil, Dr. Yuvaraja, and Dr. Sudhir Rawal sir. I have included your initial and I've already forwarded the presentation, sir. So you can hear me, isn't it?
Yes.
Yes. Yes.
So just for some ground rules, majority of the questions are because I tend to follow the EAU guidelines and they are more clinically orientated. That's what I have tried to cover. And any questions wherein I think might have an impact for Indian practice, I'm going to request answers from Indian faculty as well, whether it is acceptable or practical usage. So just looking at just before we diagnose, I just wanted to see where do we stand on the diagnostic pathway with respect to diagnosing non-muscle invasive bladder cancer. So we start off with a 71-year-old gentleman, history of visible hematuria. 71 is for a reason, and had an ultrasound scan, because this is how patients tend to come. They would have an ultrasound scan out of kilter and they come to you with a bladder lesion and the blood tests are normal. So just the next step of the investigations, which one do you think, Manu sir, do you think CT urogram would be the next step that you would like to take?
Yeah, ideally, like our patients, certainly, we go for CT urogram while planning the initial investigations for 2 or 3 different reasons. One is obviously it's one of the guidelines for us to consider CT urogram as upper tract thing. So we look at 4 different things. One is we need to make sure that the upper tracts are okay, both cortical breathing and also the collecting system. Secondly, you want to look at the other pathologies such as stones or a malformation, any number of things. Thirdly, CT urogram also gives some idea about the function of the kidney, both in the right and left side. Lastly, it gives you information about the bladder as well, and also any evidence of any other pathology such as lymph nodes. So ideally, I will go for CT urogram as a part of the investigation whenever it's feasible.
And just let's say if it was a 1 centimeter lesion on the ultrasound scan, you would always get a CT scan.
For visible hematuria, I will do CT urogram as a part of the investigation, which is a part of the guidelines for us. It's not for the mass alone, it is for the visible hematuria.
Visible hematuria. And you would do that before the TURBT for all patients?
Correct, sir, if it's possible. Yeah.
Badrinath sir, would you say MR urogram is the current standard as well as the future, especially with the VRATs being described as the best way to assess the depth of bladder invasion?
A very interesting question, and I appreciate you asking this. I think one could say this is probably where we're headed, but I don't think we're there yet. Because as you know, the MR urogram is good. Not everybody can read it as well. Not the technique matters. The Tesla of the equipment matters, whether it's 1.5 or 3T. And also depends on whether the patient has got renal dysfunction or not, and whether they can get adequate amounts of the correct kind of contrast. The biggest issue is also, upper tract studies, whether you can adequately identify stones and other lesions. I know now they're getting really good at identifying even stones. And for sure, kidney lesions, you can certainly depict them. VI-RADS, I think, has value, but at this point, it's not universally deployed. And though PI-RADS for prostate cancer, people have more experience with that. Even there's a lot of inconsistency. So VI-RADS, that people have even less experience with that. It's not been officially included as part of any of the guidelines. So I would be hesitant to using that as a first step. I would certainly proceed with the CT urogram. The one thing that becomes a tricky issue is if you do the CT urogram and it's all negative, now you only have the bladder tumor and you want to stage that by imaging, then it means you have to get a second study, which is an MRI. So I think that's where we're stuck. And more importantly, even if you did the second study and I identified on the VI-RADS that this is muscle invasive, what are we going to do? We're still going to need to get pathology, right? You're still going to go and resect the patient and prove that it is muscle invasive. So exactly how VI-RADS based detection will or assessment will change our management at this stage is still unclear to me.
Thank you. So you think that is the way we are going, but we are not there yet?
No.
And the second one would be a 3 Tesla has got an advantage compared to 1.5. So whenever we want to use the VRADS, you think 3 Tesla would be the baseline thing that we need?
The better the resolution, the better off you are, yeah.
Thank you. Sudhir sir, for Indian setting, do you think PET-CT is the panacea for all questions and all answers?
No, in bladder, especially if you see the non-muscle invasive bladder, I don't think PET-CT has any role because I don't think most of the time they don't metastasize. Even people say 5% of they can, but I don't think PET-CT should be done for non-muscle invasive. But definitely, if the patient has got muscle invasive disease or even T1 high burden disease, it's a lot of tumor in the bladder, there's PET-CT is helpful many times in diagnosing the lymph node status and even metastatic disease, which silently may have gone to the bones and liver or lung. So in non-muscle invasive, I will not do PET-CT at all.
So I would just rephrase the question. So if you have a visible hematuria patient with a lesion noted on the ultrasound scan, your go-to investigation would be CT urogram as well.
Yes, not PET-CT at all.
Thank you. Yuvraj sir, urine cytology, do you do it in all visible hematuria patients? Or if you do it in some, when do you do it and where do you do it, sir?
In the initial diagnosis, I think urine cytology is one of the investigation we do almost for all patients. Where I don't do urine cytology, if the patient has got gross hematuria or gross blood passing, so we don't do it. Otherwise, along with the CT urogram, we generally advise urine cytology in the initial diagnosis. Of course, in the follow-up, we do for everyone, and it precedes cystoscopy in all patients.
And it is mainly so that if it is cytology is positive, you are looking at there might be CIS, you might be tempted to do more biopsies of areas
high-grade disease. Yeah, it implicates high. I'm looking at high-grade disease.
Okay. So you would do it in the initial assessment as well as before you do the cystoscopy, mainly in high-grade patients. Thank you. Just looking towards the future, sir, Dr. Wait, do you think any of these investigations, you would say you would do the ultrasound scan and then the MRI scan shows that there is evidence of muscle invasion? Would you just be happy to go down the line of neoadjuvant chemotherapy? If you can take the first and the second one, sir. Any of these investigations do you think will replace either the initial TURBT or the need for the redo TURBT?
No, I don't think so. I agree with Badri. You can't make these determinations based on imaging alone. And so always would get a resection. We need to know the grade, we need to know the stage, and these need to be determined pathologically. So I don't think any of these can replace those, the actual resection of the tumor. It also not only gives us the pathologic stage and grade, but it also is the first step in treatment for the majority of patients. And most, at least in the United States, 60+% are non-muscle invasive, so wouldn't go on to neoadjuvant anyway.
And the second one, redo TURBT, let's say that you do the VRATs and it says that there is high probability that this is muscle invasive. Though you've got the histology which is in keeping with T1, would you be more tempted to say, okay, we'll go down the line of early cystectomy or ideal cystectomy or in that way compared to doing a redo?
Well, after initial TUR, the urograms, both MR urograms and CT urograms get more difficult to interpret in terms of invasion. So I still wouldn't make determinations based on that. And for any T1, I would redo the TURBT to get a better sense. And even for if it was a referred high-grade TA, but no muscle, and I didn't do the resection, and I'm not confident that they actually maybe got it all, I would redo those TURs as well in some cases.
Okay, thank you. Gendel, do you think because there is a variability of practice in India wherein ultrasound scans seem to supplant cystoscopy, I'm not saying I would support that, but do you think in the future, any of this investigation can be used instead of doing regular check cystoscopy?
Unlikely, Sanjay, because most important factor is to detect the high-grade tumors and especially the flat lesions of high grade. It's not possible to detect with the radiological investigation, and cytology is not 100% fast proof. So, in detecting early high-grade lesions, all these imaging may not be adequate. So, unlikely that this can substitute a cystoscopy. Early biopsy of doubtful lesion is very important.
Super. So we did a rigid cystoscopy and a TURBT. And I'm just going to ask a quick one. Do you do monopolar? If so, in which situation would you prefer a monopolar TURBT?
I use both monopolar and bipolar. The specific conditions at which I prefer monopolar is a large tumor where there is a high chance of bleeding because I feel that monopolar has got a better hemostasis. Regarding tumors near to UJ, I don't find much difference between bipolar and monopolar regarding the obturated jerk. There are some papers on that. So basically, it's a large tumor where the tumor is encroaching onto the prostate. I prefer a monopolar over a bipolar. Otherwise, it's almost same.
Dr. Wade, would you prefer bipolar for exactly the same reasons Dr. Ginil has mentioned?
Well, the older generation bipolar, I didn't like. I didn't feel like it engaged or cut as well. You'd have to really push it up against the tissue before it would bite. But some of the newer generation bipolars work really well and give a similar resection efficiency to monopolar. So I had historically almost always used monopolar, but more recently I've been using bipolar with a newer one that seems to work a little bit better.
So for you, the old standard was monopolar, but more and more you're using bipolar.
Right.
And for tumor, you would use a bipolar or a monopolar?
You broke up a little bit. What was your question?
For a bigger tumor, which is around 4-5 centimeters in size, would you prefer to use a bipolar or monopolar?
Yeah, I sometimes think it's interesting. Sometimes I think about using bipolar sometimes on a bigger tumor because I think there's a higher risk of getting some dilution with bleeding, and you can use saline with that. So sometimes I think about it a little bit more with a bigger tumor.
Okay. En bloc resection, sir, Sudhir Rawal, sir, do you think that is the only way to do it?
If it is possible, one should do en bloc. In many centers, people are doing, those who have become expert, they even offer for even 3 centimeter lesion because if you see scientifically, or if you just say that all the tumors, they are removed in en bloc, like kidney or prostate, even the muscle invasive bladder cancer, you remove whole of the, you don't cut the bladder or you don't cut the kidney, even the partial nephrectomy also. Same thing, if you can offer in bladder, there are advantages of getting muscle more, and the another thing that seedling of cancer cell will be less. There are some studies have shown. But in my practice, being tertiary cancer center, I get very few patients who may be fit for this type of en bloc resection. Most of the time, they have high burden tumor in the bladder already has had TURBT done outside, and they come with the diagnosis. But definitely it is preferable whenever it is possible, and it should be offered.
Mano, sir, laser fiber for the en bloc resections?
No, I don't do too many TURBTs these days. My colleagues mostly do that, and they use a thulium laser in our department. Many faculty use it, and the feeling is that the operator reflex is less, perforation is less, and you can remove the tumor. Particularly when you have a blue light cystoscopy plus the laser, it works better for us. It's a good alternative to TURBT in a regular way. So most of the procedures are being still done with the monopolar, bipolar. In selected cases, they're using thulium laser, but I don't have much experience with it myself.
So most of the cases are still done using the diathermy until there are selected cases which will be
correct
done using
in my center, yeah.
Badrinath sir, do you think we should always be using some sort of enhanced imaging, whether it is photodynamic diagnosis or narrowband imaging, in the initial stages when we are trying to be sure what we are treating?
I would say most of the time, not always. In my opinion, obviously narrowband imaging is very helpful in the outpatient office setting because it's easy. You just press a button. You don't need installation. It's much easier to use. but is also, in my opinion, less useful. Really, I can only, the only times I've found it helpful, if you see a sort of a red patch or you have lots of red patches and you're just trying to distinguish them from glomerations of vessels, but it's not really been more helpful than that for me in finding new tumors or things I did not see. But I think PDD is definitely helpful. It will help you see things much better, especially CIS, but even more of the papillary tumors, as all the data suggests. There is obviously outpatient PDD. I have found that to be a little harder logistically to do. We were part of the original phase 3 trial. It's logistically, it's quite difficult. But I think using it in the OR for resection is really helpful, and it really helps you identify tumors and completeness of resection, as well as more thoroughly inspect the bladder and identify areas of CIS. The other thing you can do now with PDD is also, if you find multiple areas of CIS, you don't have to biopsy all of them. After you get a couple of biopsies, you can more thoroughly fulgurate all areas of CIS. And actually, there's emerging data now suggesting that more thorough fulguration of CIS in the bladder can enhance responsiveness to BCG therapy. So maybe there's some value in ablating all areas of CIS that you can visualize. Where I would not use PDD or have not found it helpful is if a patient has a lot of gross hematuria, it won't help you because you go in there and there's a lot of blood and it really won't tell you much. So that's the case where I typically don't waste the money to do the PDD.
Thank you. Yuvraj sir, what is your standard way of doing TURBT, monopolar or bipolar?
Standard treatment, what I do is the monopolar one, the complete resection and the general anesthesia. So there is no difference. So I have not used any of these techniques apart from monopolar. So we are old generation, most probably now we are becoming old now. So anyhow, so that is the standard technique what I do. There is no difference.
Can I make a comment on Yuvraj? Yuvraj's name itself indicates that he's not old. How can he be becoming old? That's not.
He will never become old.
Yeah.
Bipolar TURBT, there were 3 tumors away from the ureteric orifices, one lesion approximately 3 centimeters. I just needed to highlight when Dr. Ginil mentioned in the risk criteria, it said it is greater than 3 centimeters. So this was approximately 3 centimeters inside. And intravesical mitomycin was given post-resection because I didn't know what actually was the histology. Do we have any Cytobin in this setting, sir?
Yeah, absolutely. I mean, all the data now really is very strongly in favor of gemcitabine, and I have switched completely to gemcitabine in this setting as opposed to mitomycin for 2 reasons in the United States. One, obviously, the toxicity of gemcitabine is much better tolerated, much less systemic side effects. And the second is cost. Gemcitabine is pennies on the dollar. Mitomycin, interestingly, is quite expensive. It's about $700 per installation here. And the reason is because not only one company makes mitomycin. I mean, we have to get it from Canada, whereas gemcitabine is much more widely available. So we have, that is part of our routine protocol now. In our post-op orders, gemcitabine is a default drug.
Find it more efficacious compared to
no, I wouldn't. I don't know. Strictly speaking, I cannot give you a correct answer because there's not been a head-to-head comparison. What I will say is that it is at least as efficacious as mitomycin C. Now, we submitted an AUA abstract. We've done a cost-effectiveness analysis for the two. For surely, gemcitabine is, cheaper and about the same effective. So, in terms of cost-effectiveness, gemcitabine is the better drug to use in this setting.
It's 2 grams in 50 ml.
Yeah.
Dosage of gemcitabine, 2 grams.
Well, yeah, same about 2 grams in 50 ml, 1 dose. That's it.
Thank you. So the histology has come back as low grade or grade 2 superficial urothelial carcinoma. Lamina propria not invaded, and the muscle was there but not infiltrated. Overall tumor volume was big in that it was 10 grams. Okay. So we are looking at a low grade NMIBC. What are the options? I just wondered Manoharan's view. I was just looking at this. It looks almost the same, whether we are calling it as grade 1 or pun lump or grade 2. Or, I know, at least for me, we are not big enough to alter what has been decided by WHO. But I thought all of us understood grade 1, grade 2, grade 3, and then we make into this. And there is quite a bit of an overlap. Do you think it is useful?
No, I think like I think Ginil covered it quite well. I don't think like a pen lamp just belongs to grade 1. It's just a little bit less than grade 1 will be pen lamp, I think. And however, as you know, like a grade 1, 2, 3 was easier for the pathologist, confusing for the clinicians. But when it came to low grade and high grade, it's easier for the pathologist and easier for the thing. But however, inter-observer variation was very high. And hopefully the newer things and with the newer molecular markers such as P53 or FGFR3, all those things can make it better. But right now, I think everybody agrees that like we can look at both old version and new version together and make a decision together. That's what we look at it.
So we are going in the right direction. We haven't arrived there yet.
Sure, unless we find that wrong.
So this one, we used to use the word polyp, and then it says do not use the word superficial bladder cancer, and the strength of rating is strong. Rahul sir, do you feel so strong about not using the word superficial?
See, I think I remember in few conferences when this thing came, Mark Soloway was used to, somebody uses superficial bladder cancer, he will be criticizing that guy like anything. And we stopped this completely. We are not doing it. But then it was there. Once we used it since my MCS urology days till I think 2004 or something. And then the superficial bladder cancer, they said it is misnomer. It is better to be invasive and non-invasive. Okay. And this is how it came. So I use like non-invasive and invasive. I don't use superficial.
NMIBC as the standard way of addressing this. I was mainly the strength of rating is strong, so I just wondered seniors view on this. Okay, so this used to be the stratification. There were just a couple of things I want. So if we added this patient, he would go into the intermediate in that he had 3 lesions, more than 3 centimeters in size, and that's where he would fit in. Okay, he might fit in here as well, in that he might fit into the high risk, but it used the word recurrent in the 2021. So there was a recurrent usage. Whereas if you look at the 2021, there were the 3 risk factors: age of more than 70, multiple papillary lesions, and tumor size more than 3 centimeters, not equal to 3 centimeters, more than 3 centimeters. Do you think it's a big risk factor, age of more than 70? I could not understand. I know that it was found to be on multivariate analysis, found to be a predictor of outcomes. Badrinath sir, you take age significantly into consideration?
I would say qualified, yes. It's not so much the biologic age, it's not the chronologic age, but really the biologic age that matters. Now there's increasing data looking at things like frailty, overall geriatric assessment, and overall physique assessment, which really will be a better guide of who is a candidate for cystectomy or candidate for any aggressive therapy. And that doesn't have to be, I personally have had a family member who was 75 who had a cystectomy and ileal conduit and is doing fine 10 years later. So you cannot really use age to write something off. But I would think it would be very important to do a careful and thoughtful assessment of the overall comorbidities and see how well this patient can withstand any further therapy.
Thank you. Dr. Wade, whenever we are talking of a low-grade multiple tumors, are we talking of a field change that like we talk about CIS? Or this is totally different? Here we're talking of a low-grade multiple tumors.
Yeah.
Here. Is that similar to the field change we talk about CIS, or is it different? Biologically, that different?
They behave differently. If you have a solitary low-grade tumor versus multiple tumors, the recurrence rate is higher, the progression is higher. So there probably is some change, and it probably depends the setting that they're in, whether it's a primary diagnosis versus follow-up, because we know, with a large primary low-grade tumor, if it's resected and you don't use post-operative mitomycin or gemcitabine, you have a risk for recurrence, and we know these tumors are very prone to seeding and could easily seed. So I think it depends on the context, but in general, multiple tumors behave differently and more aggressively than solitary tumors, even if they're low grade.
Thank you. So
Sanjay, can I mention one other thing in terms of age?
Yes, sir.
So one thing you have to keep in mind is responsiveness of patients to intravesical therapies, whether it's BCG or so. That does seem to be connected with age. 70 is not the age. We have found association. If somebody's over 80, we've found that there's a significant drop in responsiveness to intravesical BCG and perhaps a higher recurrence rate. So there is some immune energy that tends to occur as you grow older. They are not able to mount as much of an immune response. So in that context, but not at 70, it's much higher.
So these are the three risk factors that I've already highlighted. So actually, when we put our patient in the previous one, he was in the intermediate, whereas if we use it in the 2021, because they have taken out the recurrent, he falls into the high risk. So he's a low-grade TA, no CIS with all the three risk factors, 71-year-old, multiple lesions, and the tumor, one tumor being more than 3 centimeters. So if he was treated in 2020, I would have gone down the line of mitomycin, probably was intermediate, whereas in this one, we are thinking more line with BCG. So I just wanted to highlight which way we were going. Manosa, I just wanted to ask this question of recurrent and primary tumors. When we say recurrent, especially low grade, I'm not talking about high grade tumors. When are we talking about recurrence? In that, when you do a resection and there is a tumor at 3 months, is that a recurrent tumor or is it something that we haven't resected? It's a persistent tumor.
So I think like if you see a low-grade tumor in 3 months, usually it's a missed tumor rather than a persistent or recurrent, but you just didn't see it and didn't do it well. But whereas that's why we do the cystoscopy at 3 months to make sure that we do not miss any cancer. Then you also do it again in 9 months time later to make sure that whether some new occurrences happen. So I always feel the 3 months low-grade disease is a persistent tumor or a missed tumor.
So the 9 months one is the one where you would say it's a recurrent tumor.
Possibly because after 3 months, the cystoscope is negative and a new one comes up here.
Thank you. So it's just that they have taken out recurrent tumor out of the new stratification. And I felt that we are putting a lot more patients into high risk, and we have to consider BCG a lot more or radical treatment a lot more compared to what we used to do before. Because this category, which is low grade, multiple tumors with one tumor more than 3 centimeters, generally you would not offer primary cystectomy. You would generally go down the line of BCG, whereas previously you would have just said, okay, let's try mitomycin and see what happens because you have got a low grade tumor. So that's why it is making us think a bit more, because the way they have made it as an EAU risk stratification. Before they used to call it as risk stratification based on the EORTC studies, whereas now they have almost branded it and said this is the EAU 2021 risk stratification. So I just wanted to, when I was reading the 20 and the 2021, if you have a single papillary lesion less than 3 centimeters in size reported as a low grade, in a 70-year-old, it becomes a low grade. 2 papillary lesions less than 3 centimeters low grade in a 70-year-old becomes an intermediate risk. 3 papillary lesions, if one of them is more than 3 centimeters, reported as a low grade in a 71-year-old, it becomes a high risk. So the gap between them seems to have become a lot more closer compared to what it used to be. I mainly wanted Badrinath sir to comment about, do you think low grade ones also progress? Sir? So we know that these are low.
Yeah, so low grade ones can progress, but the progression rate is under 5%. And a very, very small number of these. And surely, as Soloway and many others have now shown, that some of these you can just do surveillance and you don't have to immediately do anything, or you can just fulgurate them and that's all effective. But I must say I disagree with this 70-year stratification. I have no idea what that has, what evidence they are presenting for association with disease biology at that cutoff. To me, it doesn't make any sense.
It's just that it only came up last month, so I just had my doubts. So this one, at 3 months into the resection, there were 2 small lesions. Would you give them again mitomycin? If you remember, we gave them mitomycin at the beginning. Ginil, would you give them again mitomycin?
In this scenario, again having an adjuvant treatment may not be beneficial because already there's a recurrence and already a mitomycin treatment is given.
I'll ask Yuraja sir, do you give mitomycin whenever they are low-grade tumors every time you do a resection, sir?
We don't have any data on these things. I think if we're planning not an adjuvant a 6-week cycle, I think I would go ahead and give mitomycin.
If you're not planning an adjuvant 6 weeks one, you would give an immediate post-op one.
Yeah.
Just a question. You're asking about the role of immediate post-op when you're doing a re-resection, say 3 months, 6 months later?
Yes.
Yeah. So the reason for post-op immediate installation of mitomycin is to prevent reimplantation, I thought. Correct. So every time you resect something, there is always a risk for it. So do we lose anything by not giving mitomycin or giving mitomycin? So I thought I will give mitomycin every time I see a new tumor. Like, for example, I did TRBT a year ago. I'm doing one more again and a year later. I would rather give single dose mitomycin in that situation as well to prevent reimplantation.
I was trying to find the expert evidence to do what I do, which is I give mitomycin every time I do a resection, mainly to decrease the chance of implantation. I know there isn't any evidence on that. Badrinath sir, anything to add on that?
No, I think you can give mitomycin again. I don't think there's anything wrong. But if you use gemcitabine, you can do that. But in this patient, if there's a recurrence, at the 3-month mark, now that suggests that this person has progressed from low risk to intermediate risk disease. So yes. Theoretically, if this was the first time, you would probably give mitomycin or some intravesical chemotherapy. But if it's a repeat occurrence, then you may want to progress to BCG, even in this intermediate risk context.
So we did a resection, and this has come back as low-grade T1. Dr. Vaid, do you think low-grade T1 exists on a long-term basis? What I mean by that is, do you have any patient who was always a low-grade T1?
No, I've had some that have been recurrent, but almost always they invariably progress to something more aggressive, both either in grade or stage. It's interesting. There was a recent publication where they looked at this entity of low-grade T1 to try to determine, does it really exist? And there was a reduction over in the United States, at least in the SEER, Medicare, as well as the National Cancer Database. This entity of all T1s, they looked at the low grade, and it cut in half from about 30% to about 15% over the last 7 to 10 years. So it may be that there probably are a small group of invasive low grade tumors, but probably more often than not, there's probably some high grade elements in there that maybe weren't seen or weren't captured by the pathologist, is what I suspect.
Can I just rephrase the same question and ask Badrinath, is low-grade T1 a transitional phase before a high-grade NMIBC, or is it a distinct pathological entity, sir?
The answer is, I don't know, and I think most people don't know, probably. Whether because just not in the context of this, but in the context of most other diseases, it's presumed that low-grade can progress to high-grade over time. We know stage can change, but whether a change in grade indicates a change in disease biology, you're going from a less aggressive to a more aggressive variety, that means subsequent genetic changes that need to occur. And that has not yet been proven. Of course, it sounds logical, but at this point, I don't know that we have evidence to suggest that, you start as low grade, something occurs genetically, and then you become high grade. We don't have that evidence.
Thank you. So I reviewed both the histology, and both of them were reported as low grade T. So review cystoscopy in 3 months. There were 3 lesions, all of them less than 3 centimeters. And now he's definitely coming into the intermediate risk, or if we use the 2021, he's probably coming into the high risk one. So low grade A, adjuvant treatment, is mitomycin the best one to use, or probably Badrinath sir uses gemcitabine? Mano sir, do you use mitomycin in this? And what would be?
I would normally go for Bcg, but because the question is what I would do with mitomycin, if I'm going to use a mitomycin, it will be like I use about 40 milligrams, 20 cc of water once a week for 6 weeks. But I will go for a Bcg in that situation.
Okay. And do you use mitomycin maintenance after giving the 6 weeks?
If I'm given mitomycin as a primary treatment, then I will continue with the mitomycin as a maintenance as well. But as I said, I will rather use Bcg in this situation.
Monthly for 12 months. Yeah. When you use mitomycin. Okay, so, but you would use Bcg in this.
Correct.
Raja sir, you would use intravesical heated mitomycin in this setting?
I use either intravesical mitomycin, heated mitomycin, or Bcg, give the option to the patients. So we have now almost 35 patients who are on, especially for low-grade tumors, and both do well. So it's just a patient's choice. So that's how we treat these patients. So we recently published the data on mitomycin, heated mitomycin, 22 patients comparing with 25 patients, very small data, 16 months follow. The side effects are hardly less than 5%, and the recurrence rate at the end of 16 months, so there was no difference.
So this
it is coming up in urology annals.
So heated mitomycin versus Bcg.
Bcg.
Okay. Intravesical Bcg would be a standard, sir. Rahul, sir?
Yeah, he's actually failed 3 times and he's got 3 lesions. Probably the BC is the best treatment. Only thing that one has to beware of side effects of BCG. You have to tell the patient that he may have side effects which can be very troublesome sometime, and we do see a lot in our practice. It's not very uncommon, but it's very common, and that is why most of the low-grade TA, either they go for mitomycin C or they go for HIVEC in our center. Generally, I do not prefer BCG unless it is mandatory in our center, but definitely BCG can be given to this patient because he's failed 3 times.
Thanks. Dr. Wade, gemcitabine, do you think good option?
Yeah, I would typically use BCG here as well. I really thought Dr. Prakesh's talk was interesting, and I wonder if there's more BCG toxicity in India due to some of the factors you mentioned, but I haven't seen that same thing. So I would have normally offered BCG, but gemcitabine is an option either if they failed or have insensitivity.
Thank you. So I gave him mitomycin, and then he had cystoscopy at 9 months, which showed high-grade T1. Badrinath, sir, this statement I just made, patient at the start had a low-grade urothelial malignancy and then progressed to high-grade disease. I know you clarified it, but do you think biologically it happens, or a low-grade always remains along a low-grade?
Like I said before, I don't know that we know one way or the other, because there's another thing we have to keep in mind, right? Given that it's a field change phenomenon, you don't know when they have a recurrence, if that original low grade now has come back as a high grade, or this is a completely new tumor that's growing somewhere else that's a high grade. And there's all these ideas of clonal growth. You have to actually perhaps do P53 mutation analyses or other genetic analyses of both of these tumors, the previous one and the new one, to really understand if there's any correlation between the two. If they are related, if there's similar genetic abnormalities, then one can say, one can be related to the other one. Without that sort of examination, it's going to be hard for you to assume that it's progressing. But whether it was progressing or not, I think you know that now you have high-grade disease and you just have to treat it as such.
Okay. And this statement, low-grade can progress to high-grade NMIBC and then on to high-grade MIBC. Does that happen in that sort of a stepladder fashion, or you don't know? You wouldn't.
We cannot say that for sure without routinely, even in an individual case, without routinely examining all of these. But even if it did, really, you would be treating whatever you have, the biology at that point, right? The high-grade T1 disease. So whether it progressed or not, do you think it'll make a difference? I mean, I'd be interested in seeing what others think, whether we should treat these differently. What if it was a de novo high-grade tumor versus one that progressed to the next one? Are you implying that your treatment will somehow be different for these two?
That's why I was asking the question about de novo tumor compared to recurrent tumors, whether the tumor has evolved.
Yeah, I don't think the treatment at this point, based on the evidence, we would not treat it any differently. You would still treat the high-grade T1 as you would any other high-grade T1. In that, you could offer BCG at least for an induction course, and if that fails and they come back with another high-grade T1 or higher, then you would take them to cystectomy, in my view.
Thank you. So there's next one is a 60-year-old with a history of hematuria, investigated, found to have 3 tumors, with a couple of them around 4 centimeters. Reported as a high-grade TA, detrusor muscle was clear. So, Mano sir, you have answered this, but just to highlight the numbers, if you can give me what are the chances of being recurrence-free at 5 years if you go with radical cystectomy?
So obviously you're going to do RTR, BT, and all the other things. Let's assume you've done that and then do a cystectomy. As I mentioned earlier, if it's a T1 disease, chance of being recurrence-free at 5 years is more than 90%. In our center, it's actually 95%, actually. That's a good number. And the chance of being cystectomy after BCG depends on what the stage. Again, if you do the BCG and fail, still it's a T1 or a TA. Again, the survival figures are still above 90%. And after BCG, you allow the disease to become T3 or a T2. Again, the numbers are going to go downhill. And when you do a cystectomy in a T1 stage, the situation, there is a higher chance or a higher inclination from the surgeon to do a neobladder because the patient is more likely to be fitter and more suitable for the neobladder. So I do not have any concerns of doing a neobladder in this patient. The indications and contraindication will be the same. The overall complication is an interesting question. For me, the complications of the cystectomy does not come from the cystectomy itself. It comes from the other things, the diversion, patient and his lung and other things. But however, the only complication will be different, maybe the blood loss. In the modern days, the cystectomy blood loss is not that much. So doing a T1 cystectomy is slightly easier than a T4 cystectomy. So I assume that from blood loss point of view, timing wise, it may be better, but otherwise overall complications unrelated to the cystectomy itself, I think.
When I said concerns regarding the neobladder, I was mainly asking, are you worried that this might be a field change in that there are that many lesions in the bladder? You're not worried about it?
That should not affect my decision to do a neobladder. It should be a standard indication contraindication.
Okay. So, Badrinath sir, BCG is an appropriate option for this gentleman who has got multiple lesions, some which are 4 centimeters, has been resected and has been found to have a high-grade TA. If you can give me chance of being recurrence-free at 5 years, sir.
This person chance of being, I would, in this kind of context, I would go back to using the EORTC calculator and you put the numbers in. I think this person's chance of being recurrence-free at 5 years is going to be less than 50%. His chances of keeping the bladder will be higher than that because the likelihood of progression, which is what would decide whether the bladder stays in or not, even with high-grade T1 in the old ERTC and even with the one that's been modified using BCG data, is still around 15 to 20% risk of progression with patients with recurrent high-grade TA. So you still probably have about a 70% chance of keeping his bladder intact at 5 years. And the overall side effects, I guess they're cumulative. The more mitomycin, the more BCG you give this person, you're going to, with each subsequent course, notice more side effects. But there are some people who, for some reason or the other, can tolerate multiple doses of BCG and not have side effects. So it depends on the individual patients. But in general, they will tend to increase. I think the chances of finishing 27 doses are reasonably high. As you know, from the original SWOG study, only 15% of the patients actually completed all the 3 years worth of maintenance BCG. But that has not been my experience. I think the predominant majority, I would say probably 70 to 80% can actually complete the intravesical BCG. And the reason for that is in the SWOG study, what they did was not just give intravesical BCG, they gave intravesical BCG and subcutaneous dose of BCG at the beginning. So there may be some thought that this dual stimulation increases the side effects. But even though, if you look at the European URTC trial, the Audience trial, the completion rate was rather high. So I don't think the drop-off is as high as in the original SWOG study, because that was 85% dropout. It's not as high anymore.
Thank you very much. So, do we need to do culture before each BCG, sir? Sudhir, sir?
No, as this has been highlighted already by Badri, that first time when you are giving BCG, you should do the culture, and if it is sterile bacteria, even then you can go ahead with the BCG. I've seen some reports that even with BCG helps in killing the bacteria because you do the immunity get enhanced. So it's not that every time you should be doing the culture before giving BCG.
So we have answered this question. Does the strain matter? Probably not. Does the dose matter? I think we'll be debating here until tomorrow if we answer. Is LAM protocol the best one, Dr. Wade?
I think it's the one that has the most evidence and the one we should follow as a default if we can.
Okay. The next one is, does it matter if the patient is on warfarin? Yuvraj sir?
Yeah,
So,
I think on warfarin and steroids, I don't feel any major difference. So we do give BCG. So we I don't know much about that.
and anybody with HIV, sir? Mano, sir, do you have any concerns or you don't?
Sure. If I can give a slightly longer answer, like I did work in Jackson 20 years ago, where we had a large number of HIV patients, and also we have biggest transplant center. So we had a lot of bladder cancer patients. We did present a couple of courses in the AUA. As Badri pointed out earlier, those HIV patients without real AIDS and transplant patient did tolerate BCG quite well. But however, the recurrence rate is higher, so we did monitor them much more frequently with the regular patient. One more before in transplant patients, we always change the immunosuppressants from the regular one from Prograf to rapamycin. Rapamycin acts as an immunosuppressant as well as an antimitotic agent. So what we do in transplant patient is to change the immunosuppressant and then give BCG, meaning rapamycin plus BCG. That has worked much better, but I think they're planning to publish a paper sooner or later. I'll let you know in the due course.
Thank you. So I have done this, but I think we'll skip this just because Gagan has already covered this. So when do you assess the response? Do you assess the response after 6 cycles of BCG or 6+3? Or what is induction? Is it 6 cycles or 6+3?
Yeah, we have to have a third-month cystoscopy because it's a very important prognostic assessment. So we have to have a third-month cystoscopy, but we keep a gap of at least 2-3 weeks between the next BCG or prior BCG if the dosage is delayed.
Sorry, what I meant was, do you consider induction as 6 cycles and then you do a cystoscopy and assess, or would you give 6+3 and then assess whether patient has responded?
You mean after 6 cycles, before the next third month cycle, we have a cystoscopy. That is the
so when we did the cystoscopy after the 6+6 cycles, there was a low-grade tumor. Manosa, do you think the BCG has worked?
This goes back to the definitions of Bcg failure. I think if you see a low-grade disease at 3 months, it's called as a Bcg resistance or persistence. And I would not really consider as a BCG has failed. I'll remove the tumor and continue with the BCG.
Thank you. So I just wanted to highlight this thing. So this is a paragraph from EAU 2021 guidelines, and I am not expecting you to read it, but I'm just going to go by each sentence. Serious side effects are less than 5%. Ginil, do you agree with that?
Is around 8% we are having, between 5 to 10%, yeah.
Side effects can be treated effectively in almost all cases.
Yeah, almost all cases, but issue was patient beyond 1.5 years, the patient were not willing for continuing the BCG because of the frequency of side effects, but majority of the side effects could be controlled with routine medications like antipyretics.
Less than 1%, Sudhir sir, agree with that?
You mean BCG infection, systemic infection, or just in the cystitis?
Systemic infections.
No, yeah, it has to be less than 1%. Rather, I have not seen for a long time. I have seen one only in my life since my training in CMC. So it's less than 1%.
And I'm just going to finish after we go through the side effects. So maintenance treatment doesn't increase the toxicity. Agree with that, sir? These are all statements in the EAU guidelines, which I didn't think were totally applicable to Indian population. So that's the reason I've highlighted.
No, we do see patients who are tolerating it very well, then suddenly they develop this toxicity and they have side effects, and we either have to increase the duration of next dose or we may have to stop it. We do see a lot of side effects in our practice.
And most side effects are seen in the first year of BCG?
Yeah, that I agree.
And elderly patients do not experience more side effects, Yuvraj sir?
No, I think I'm not seeing any difference with the age, and everybody has got same tendency to. So we didn't look actually in our paper, and when you compare the strain, so I think we had that publication in Asian Journal of Urology. So now it is at print, and we could see huge difference from Danish strain versus Moscow strain versus say 48% versus 70% of side effects, moderate to severe.
But with respect, side effects are different, but efficacy is similar.
Efficacy is similar. No difference.
So just what Badrinath sir added, elderly patients seem to have a lesser of a response to BCG compared to younger patients, though the side effects might be the same. So just highlighting those same things. Okay. I think we are run out of time, but thank you very much for your company. Hope I have learned quite a few things, and I have enjoyed interacting with such an esteemed panel.
Thanks, Sanjay. It was excellent. Thank you so much.
Thank you, Dr. Sanjay. It was an excellent discussion. We are running behind schedule, and we have a couple of questions. A few of them have been answered in the chat box itself. So we will not take up any questions. Thank you, everyone. And we will move on to the closing remarks by Dr. Arun Chawla. Over to you, Dr. Arun.
You are muted, sir. Please unmute.
Yeah. Thank you, Raghu. It was an excellent webinar, very nicely scripted program by convener of Uro-Oncology subsection of USI, Dr. Raghunath. And this was done in 2 sessions. The first session was of talks. To begin with, Jinil had an excellent presentation of the stratification of the NMIBC and how important is this stratification in individualizing the treatment for a patient with NMIBC. We had Dr. Raghuvan's presentation. Unfortunately, we couldn't see the running video, but we could just hear the audio part of it. But it was an excellent presentation, and we don't have time left to rerun the presentation. Adverse effect to intravesical BCG remains an issue of concern, and this was very nicely discussed by Professor Badrinath Panetti in his presentation. I think elevating the symptoms due to intravesical BCG as early as possible go a long way in making the patient adhere to the intravesical BCG protocol, and we need to have always a proactive role in reducing the BCG adverse symptoms. He did mention about the Mycobacterium cell wall, nucleic acid, and the extracts as a substitute, but I think again the data and the evidence is lacking, and long-term studies are lacking in providing a substitute to intravesical BCG. We have an excellent talk by Professor Christopher Way in giving the options other than the BCG. He did mention about the role of nadofaragene in reducing the cystectomy-free survivals, as well as the favorable side effect as compared to pembrolizumab. It was a very exciting talk. Dr. Mohar presented about a very engaging presentation on early cystectomy in BCG failures, highlighting the importance of around 20% more disease-free survival as compared to the late cystectomy. A very interesting presentation from Dr. Manohar. And in the end, we had the excellent talk by Dr. Gagan, compiling all the data from the Indian authors from the different institutes, especially the slide mentioning about the difference in the strains between the Danish and the Moscow strain, and their adverse effect profile and the efficacy was very interesting and an eye-opener. The second session, moderated by Dr. Sanjay Adla, almost was an icing on the cake. It was beautifully conducted sessions, supported by the international faculty as well as the national faculty, Dr. Sudhir Raval sir, Dr. Yuvraj, Dr. Gagan himself, Dr. Sanjay. An excellent, and there were a lot of take-home messages and learning points. I too myself gained a lot by the case discussion moderated by Dr. Sanjay. In the end, thanks to all the international faculty and the national faculty for an excellent webinar, an excellent evening by seeing this webinar and being a part of this webinar. Thanks to Navneet and Kiran for providing the logistics. Thanks to all the viewers who have joined on the Zoom platform as well as the YouTube platform. We have more than 300 viewers logged in for today's webinar. Thank you, USI, ISU, Dr. Mallikarjuna, Dr. Keshamurthy, Dr. Rajiv Sood, and thank you once again. Stay safe, stay well. Good night. Bye.
Bye. I hope Pandemic is over. Thank you.
everybody.
Thank you, Mano sir. Thank you, Badri sir. Thank you, Dr. Wade. Ginil, all my friends, very, very grateful for that. I thoroughly enjoyed the panel.
Thank you. Thank you. Thank you, Mano sir. Thank you, Sanjay. Thanks.
Thank you, Raghu.
Thank you, sir. Thank you, sir.
Raghu, done a good job.